This is Malik Hook from the University of Colorado, and the topic today is a little bit of a tongue twister: surgical management of the glaucoma patient with advancing visual field defect and concurrent anti-VEGF treated wet AMD. This is a case of an 80-year-old male with advanced glaucoma and wet AMD. IOP is 22 with a goal of 13, currently on maximal tolerated medical therapy with previous failed SLT and visual field progression consistent with glaucoma. The AMD is likely to require repeated intravitreal injections, and control of acute rise in IOP is desirable. When the retina colleague sent the patient over for care, the two requests were to control pressure long-term, but also try and avoid the spikes that can happen after routine intravitreal injections. We've had a lot of experience at the University of Colorado treating patients post-glaucoma surgery with anti-VEGF agents. We've done this with intracameral injections, intratenon, as well as intravitreal injections, and we've done this again for over 15 years, both intraoperatively as well as postoperatively. There have been some reports of linking Bleb leaks with the use of anti-VEGF agents in patients who are post-glaucoma surgery. However, we really haven't experienced that. Many other groups have reported on the safety of anti-VEGF injections with glaucoma surgery, and you see some of the references on the bottom of this slide. The options for intervention in this particular case would be to repeat laser trabeculoplasty or to try and maximize medication use. While I said the patient was on maximal tolerated medical therapy, there is the potential to kind of mix and match and try and get better IOP lowering out of the regimen. You can also consider MIGS surgery or angle-based surgery, ECP, goniotomy, TM bypass devices, several other devices that are on the market today. Trabeculectomy could also be considered, as well as glaucoma drainage device procedures. If I look at each one of these individually, we've determined that the patient has visual field progression. We have also determined that the intraocular pressure is significantly above goal, and long-term preservation of vision requires some sort of intervention, in my opinion. Because of this, laser trabeculoplasty and maximizing medications are not likely to work in this patient who has failed both laser trabeculoplasty in the past as well as the current regimen of glaucoma drops. There is a caveat, however, with this, and I'll discuss this towards the end of the presentation. What about MIGS or MIGS++? And the MIGS++ in this case would be a mixing and matching of MIGS devices or to do an inflow and outflow MIGS procedure. This patient is pseudophakic, and much of the data that we have with MIGS procedures is centered around teaming up cataract surgery with an angle procedure. MIGS is not likely to decrease the pressure to the goal pressure of 13 in this case. It's unclear how MIGS deals with the acute rise in IOP, which is one of the problems with this specific patient. Could you mitigate the rise that happens with the repeated injections? It's likely not the best option in this patient. What about trabeculectomy? Trabeculectomy is a great option for IOP lowering, and you could argue that it's actually our best option for IOP lowering. Anti-VEGF agents may help Bleb health in this case. I've discussed the fact that we've had a lot of experience trying to rescue Blebs that are vascular, as well as using it primarily at the time of trabeculectomy. However, in this specific case, we have experiences that points us away from trabeculectomy. We reported this case way back in 2008 of a 71-year-old female with a history of trabeculectomy with mitomycin C in the right eye. She experienced hypotony and decreased vision after intravitreal injection for macular edema. And the question here is, why did she have the hypotony? Her history was significant for feeling a pop when they injected me. This is something that she literally told me word for word when I walked in to do her assessment. On assessment, you could see a fairly avascular bleb with a great deal of thinning on the superior aspect of the bleb. And with Seidel testing, you can see an obvious leak coming from the apex. It's important to note that an injection of 100 microliters can increase IOP by 90 millimeters of mercury. There's a significant IOP spike that happens with all of the intravitreal injections that we do. While this was a single case, it was enough to make me think twice about scenarios like this. Trabeculectomy blebs are variable, and ischemic blebs that are prone to injury are commonplace. For this reason, I avoid trabeculectomy in these patients. Well, what about glaucoma drainage device? They provide significant IOP lowering with long-term safety. They control acute fluctuations with intravitreal injection. Posterior blebs with less ischemia are what we usually end up with after glaucoma drainage devices, and you can avoid some of the trabeculectomy bleb risks that I just discussed in the previous slides. You also have the advantage here of being able to place it in the sulcus away from the cornea because the patient's already pseudophakic. Some of the caveats to the choice of a glaucoma drainage device: of course, you have to discuss the options with the patient. The patient might choose observation with paracentesis at the time of the injection. That's one option to decrease the spikes that can happen with each intravitreal injection. Could it be that the visual field defects are worse because of the repeated spikes? And performing a paracentesis and potentially pretreating the patient with drops might decrease the peak of that spike so that we're not seeing as much visual field progression. MIGS++, especially if pseudophakic, may actually be an option as one step prior to going to filtration surgery. And in this case, you would team up an inflow and an outflow procedure like ECP with goniotomy, for example. There are other options coming to the market or already on the market in some areas around the globe, including Zen, which is less invasive and may regulate acute spikes. A device that is not quite on the market in the US but might be available in other places for clinical trials is PreserFlow. And of course, the Express, which has been on the market globally for a long time. These are short tubes that might be a good option. And then in the past, suprachoroidal devices held some promise of being able to treat a wider variety of patients. However, the CyPass has been taken off the market, and there's a big question as to whether the Glauco Supra will make it to the market anytime soon. In summary, this is an 80-year-old male with advanced glaucoma and wet age-related macular degeneration. The patient had pressure above goal while on maximally tolerated medical therapy and also had visual field progression. The retina surgeon who referred the patient requested control of pressure, not just chronically, but also for the acute spikes that happen during the intravitreal injections that are planned for the foreseeable future. We chose glaucoma drainage device, and the patient had an uncomplicated postoperative course with IOP at goal on 2 medications. One closing thought here is that communication with the retina colleague is key. Injections can continue for preservation of vision. Make sure the retina surgeon can avoid the Bleb area with future injections. Consider a paracentesis prior to injections. Monitor closely after injections until IOP returns to baseline, and this can usually take about 20 to 30 minutes in some of these patients. IOP checks before and after injections are extremely important. It's not enough to just check the vision with a hand wave and let the patient go home. I think it's important to check the pressure. Treat and extend as much as possible to minimize the amount of injections that are required. I'd like to point you towards some other educational resources, including keogt.com, as well as the YouTube and Instagram channels that you see listed below. Thank you very much.